cord. The frontal cortex is where our executive functions and our judgment areas of our brain is. We really need to be able to use judgment. And fortunately, opioids can go directly to the prefrontal cortex and in their judgment. They also stimulate the limbic system and give pleasure and rewards. And as we all know, they can decrease respiration, cough, and pain in the brainstem and spinal cord. Next. Now, the opioid receptors that are present in the brain and in the spinal cord are modulated. The brain can produce more of them, and it can produce less of them. So after there's an injury to tissue, spinal cord receptors will become available on the surface of the cell. That allows for more of the natural endorphins to bind and activate those receptors, but also for opioids that we give to a patient to bind to those receptors. Because there are so many receptors available after acute injury, any of medication or endorphins produced by the body can into those receptors, and because they're bound, they're not go over the body, and that allows the patient to tolerate that dose of medication without overdosing. There are not so many receptors available, like a person who has not had an injury, then receptors are downregulated, and the same dose for the same patient could cause an overdose. So it's important to remember that tolerance or that ability to tolerate a dose is very different even in the same individual or time, depending on what has happened to them recently. And when somebody is in extreme pain and their receptors are upregulated and they take opioid, they typically do not get high. It helps control the pain. Next. Over definitions of tolerance and withdrawal. Tolerance is the need for increasing amounts of a substance to achieve the desired effect. You have to keep more and more to get drunk, or you have to keep taking more and more Vicodin to have pain control. We all, as physicians, have probably seen this in a variety of settings. Withdrawal is the physiologic response when a drug or a substance is withdrawn rapidly from the, and then the receptors are left without anything bound to them. And, or if a blocking agent is present and is blocking the binding of an agonist to the receptor, then the body has a response to that drastic change in the stimulation of that receptor. Discuss opioid symptoms on the withdrawal symptoms on this slide. So there is dysphoric mood with opioid withdrawal, nausea, vomiting, muscle aches and cramps, lots of runniness everywhere, runny nose, runny eyes, fast heart rate, hypertension, sleepiness, and diarrhea and insomnia. So it's pretty miserable to have opioid withdrawal. Opioid withdrawal can be measured on the clinical opioid withdrawal scale or the COWS scale. There's just little forms that you can download to them. So it's very easy in clinic to use a COWS and rank how severe opioid withdrawal is for one of your patients if they come in an opioid withdrawal. And that also can be used to help monitor Suboxone therapy or buprenorphine therapy if you have your patients on that. The length and timing of the withdrawal period will change depending on half-life of the opioid that has been used. So short-acting opioids have a short withdrawal period. So things are in or hydrocodone, the withdrawal will last, usually about 3 days, but at the most about 5 days. It's pretty miserable during that time, but it's over in a week, certainly. And it can begin anywhere from 6 to 12 hours after the last dose. So for patients who are using heroin, if they're going to be on withdrawal about 4 hours after their last dose. These are people who are using 4 or 5 times a day to prevent themselves from going into withdrawal. Launching opioids such as methadone and buprenorphine, the withdrawal can begin several days after the last dose and peaks in 4 to 5 days, but the entire withdrawal period can last up to 2 weeks. Next slide. A bit about the history of opioid use in America. Opioid in the Civil War obviously was very prominent because there were a lot of injuries. There's a picture of a hypodermic needle on here. There was extensive use of hypodermic needles, although they had been invented by the Civil War. A lot of pills were actually used in opium tinctures during the Civil War. By the 1800s, opium and heroin, which was invented in 1874, had it and started to cause problems. And Harrison Drug Act was the U.S. government's first attempt to or ban heroin and get some of these things under control and not so many people becoming addicted to opioids. In the 70s, during the Vietnam War, as we all know, many people became addicted to heroin and other opioids due to injuries and also just due to the tragedies of war of our veterans while they were over Vietnam and then came back home, and there was not very good treatment for many of these veterans returning home, and the stigma of having an opioid addiction stuck to them in addition to the stigma of the trauma of the war that many Americans felt. And so it was hard for these people to have double stigma on them. In methadone was invented in 1974. That is prescribed mostly through methadone clinics. We'll discuss that a little more later. And it has been very successful in helping many people stop using opioids off of the street and get their lives back together. And then went to 1999 with pain as the 5th vital sign, where that pain should be strongly treated and shouldn't just be rated or suffered through, became the mantra of the medical field, and it really swung the pendulum a little too far, and a lot of opioids were prescribed that perhaps shouldn't have been prescribed, and now that has been one of the contributing factors in the current opioid epidemic. Opioid prescriptions in the United States have drastically increased, although the population of the United States has not increased in proportion during this time frame. We can see that from 1991 to 2000, that the number of millions of prescriptions of opioids has increased about threefold. I want to talk about the Monitoring the Future study, which is a study that's been done since the 1970s, and it asks 12th graders, 10th graders, and 8th graders about their history of substance use and their current use. So it's a very long-term study, and it gives us a pretty good picture about trends in drug use for teens, and things are up and coming. There's a lot of very interesting information about all kinds of drug use, whether teens think that the drug use is dangerous, why they do it, that sort of thing, on the Monitoring the Future website. Next slide. In the 2015 Monitoring the Future survey, you can see here some graphs of the answers, 8th, 10th, and 12th graders rating their past month use of various substances. The graders are in the white bars, the teachers are in the light colored bars, and 12th graders are in the dark colored bars. And we see that over time, all groups have decreased their use of alcohol from 1995 to 2015. 3 groups have reduced their use of cigarettes over the same 20-year time period. But illicit drugs have been pretty stubborn and haven't changed very much over the 20 years, although there's a trend towards illicit drug use by the 8th graders, which is wonderful to see because posting any substance use can be protective no matter what the substance. This slide shows past year use rather than past month use on the previous slide. This is the past year use for prescription versus over-the-counter or illicit drugs. For the traders, marijuana and hashish, about halfway down is that purple bar that's really long. It says 34.9%. That bar wouldn't even fit on this graph. And it's definitely the most used substance by operators in the Monitoring the Future survey. And it is not without its harms or its risks because it can increase the chance of conversion to other substance use disorders later, including opioid use disorder. We can add third from the top, opioids other than heroin. 5.4% of traders in the past year have used opioids other than heroin. And this is for non-medical use, not just having taken it for a prescription. So 5%, that's 1 in 20. And so every 20 seniors that you see through your office for checkups before they go off to college, one of them has been experimenting with opioids in the past year. Opioid use by 12th graders has been declining over the last decade, which is really wonderful, but it's still higher than what we would like to see, so that between 4 and 5% of the 12th graders are using in 12 months. Data from the state of Massachusetts. It's not adolescent data. It is the entire part of Massachusetts, and it shows the total number of deaths related to unintentional or undetermined cause of death when opioids were in the system. And so in the year 2000, 355 people in the state of Massachusetts died from an opioid overdose. And 16, nearly 2,000 people, it's estimated, will die of a opioid use overdose. And you can see the only difference between the gray bar and the red bar is that the gray is a confirmed death, and the red is estimated. But that increase is really huge. And consider that, there were almost 2,000 people in the state of Massachusetts who died in that year. If there were 50 states and there were 2,000 people in every state, that'd be 100,000 people across the nation who had died from opioid overdose deaths. The New York Times article told us that in that year it was 33,000 across the country. So we're really leading the pack here in the state of Massachusetts. The death has also risen if you consider it per 100,000 residents, because we can imagine there might be more deaths if we were having more people live in the state of Massachusetts, but the rate is really been climbing in the past few years when it was fairly steady in the 7, 8, 9 range for the 15 previous. So something has changed in the last few years. We can see across the state, opioid use deaths are really affecting the entirety of the state of Massachusetts. The lowest areas have between 14 deaths per 100,000 people, and that's Hampshire and Middlesex. And that number, the 9 to 14, is higher now in the past couple years than the average was for the whole state for that time frame of 2000 to 2014 or so. And so now our lowest areas are what the average used to be. Slide shows us that the young people are really disproportionately affected by opioid use deaths. We see on the top bar that these are all deaths in the state of Massachusetts in their 2016, and that in the bar, that's the 65 years and older set, they account for most of the deaths in the state of Massachusetts. In the light gray bar, 1% of deaths in the state of Massachusetts are accounted for by people under the age of 25. However, if you look on the bottom bar, which are unintentional opioid-related deaths, then the gray area, which is people under the age of 25, account for 8% of those unintentional opioid deaths. The largest group is the healthy young adults, the 25 to 44-year-olds, are for 57% of opioid-related deaths in the state of Massachusetts. So there's an epidemic, not for the state, but for the state's young people. Reasons for opioid use among teenagers are listed here, and we can that there's a lot to do with availability. Teens report that it's very easy to obtain prescription opioids to misuse. They can get it at home. They can get it from a friend. It's not illegal, and because it's not illegal, people deem it to be safer than using an illegal drug. There's shame, and I don't think that there's as many side effects. And they even necessarily always think that their parents are going to care if they get caught, because it's not technically illegal to have some of these substances. So this perception of safety has led a lot of young people to use and abuse prescription medications first, and then later convert over to heroin use to that tolerance. Is similar to morphine. It has an extra group on it. And what happens with morphine is that morphine is very slow to cross the brain barrier. So it gives you good pain control, but doesn't give you the same rush or the same high that heroin does, because heroin can very quickly cross the brain barrier and get into the brain. And once it's in there, it is quickly converted to morphine. And so by taking heroin, what you're doing is delivering morphine straight to your brain in a very fast way. And that causes the high. Because heroin is very potent and it's not expensive compared to how potent it is, then people who have increasing tolerance to prescription opioids that they've been misusing, when they start to run out of money, will often switch to heroin because they afford heroin. Purity of heroin on the street has led people to be able to use it through smoking or through snorting it rather than having to inject it, has lowered the barrier to entry for a lot of people who would never think of injecting something, but they're willing to snort heroin if they're trying to combat the tolerance. The age at which a person starts using drugs, any drugs, but especially opioids, really affects whether or not they will later develop a substance use disorder. So basically no experimentation is good. And when parents say that their kid is just experimenting, that experimenting sets them up for increased risk down the road. We see that on this chart, the ages along the bottom, ranging from 13 to 21, and then the estimated prevalence of lifetime prescription drug abuse is on the other axis. And the chances of having a lifetime substance abuse problem are higher if people start using at a much younger age. 13 to 14-year-olds are in the, about a third of them who are a third to maybe a half of them who had experimenting with non-medical use of prescription drugs will develop a substance use disorder, whereas that risk is in 15 and 20% if they wait till they're 21. So they cut their risk in half. There are lots of pathways that can lead to opioid misuse, but one of them is through prescribed opioid use. Not that things start out as misuse, but when access to prescribed opioids, it can lead to misuse and increase their risks later on. Any teen who has been prescribed opioids for legitimate medical reasons, there have an increased lifetime risk of converting to opioid misuse. And the odds ratio is 1.33. So use of alcohol, marijuana, or tobacco can increase the risks of later opioid misuse. So the adjusted odds ratio for lifetime marijuana use, the adjusted odds ratio is 2.44 for converting to opioid misuse. For cigarette use, if are currently misusing opioids, and they probably were using cigarettes earlier, and then lifetime alcohol use, 2.3. So basically, use any of these substances, marijuana, cigarettes, or alcohol, can increase the odds that later on that person might convert to opioid misuse. And the reason is the brain and the mechanisms of addiction in the brain, but also part of it is societal and perceptions of risk. So teens who are risk enough that they're not going to try alcohol, they're not going to try cigarettes, and they're not going to try marijuana, what chances that they would then take the risk to misuse opioids? It's very low. And anything that you can do to encourage your patients to avoid all of these substances, it just keeps them from going on the slippery slope of feeling like, well, this one's not so bad, that one's not so bad, so then that other one is also not so bad. And if people are misusing opioids, many of them will convert to opioid addiction. So as we know, not all misuse leads to addiction, and the pathway from misuse to addiction is different for different substances. So that, for example, people who use marijuana, a smaller percentage of them convert to addiction compared to people who use alcohol. You know, more people who misuse alcohol at a young age will convert to addiction, and then from opioids it's really quite high to convert from misuse to addiction. And the things that increase that are the younger age: genetics, mental health disorders, and motivations. So the younger age is we looked at on that graph a few slides ago, and every single year that patient puts off misusing opioids or having non-medical use of opioids, their risk increase that they later to a use disorder. Depression, anxiety disorder, and panic disorders occurring with opioid use increase your risk of development of a disorder. Alcohol and drug problems increase your risk of development of a disorder. And trauma increase risk of development of a disorder after misuse. Most for opioid use are, there's them. The most common are to relieve pain and to get high, and there's some overlap in these groups, so that, you know, there's quite a few people report both motivations, but both motivations can cause risk. for unprescribed pain relief in patients who are taking opioids prescribed to someone else or taking higher doses than what were prescribed to them. So that's non-medical use. If they're taking it that way, then even if it's just for pain, it still increased their risks of development of a disorder later with an adjusted odds ratio of 1.8%. And then recreational use obviously is much riskier than for the pain relief, and that adjusted odds ratio is 3.4. In DSM-5, there was a change to the way that substance use disorders are diagnosed. In prior to DSM-5, the use disorders were called use and dependence, and those words are still used a lot frequently. But what happened as more research was done, it was shown that abuse and dependence were not actually really different things. And that there are a set of problems that tend to plague people with disorders. And then the more of those problems that you have, probably the more severe your disease is. And so there's now just one list of 11 symptoms. And then those were combined from abuse and substance dependence of the old criteria, except for craving, which is number 11. That one is a new criteria that wasn't in the old diagnostic setup. And narrative is used to talk about how bad the problem is. If you meet 0 to 1 criteria, then there's no diagnosis. But for 2 or more criteria, you have a substance use disorder of varying degrees. Of opioid use disorders should always encompass both non-pharmacologic treatment options and then as needed pharmacologic treatment options. So non-pharmacologic can be as intensive as a residential treatment program where somebody's sleeping away from their home and getting treatment every hour, to intensive outpatient or partial hospital programs, 12-step fellowships, or other peer support groups like Smart Recovery or SELVS. There's a bunch of them. There'd be individual group or family therapy or therapeutic community in school. Actually, quite a few high schools in the state of Massachusetts. And so, if you have a patient in high school who's really struggling with substance use and wants to stay sober, oftentimes a sober high school can be a very good intervention for them. On the pharmacologic side, you detox to get off of the substance that you're using, and then you can use methadone or buprenorphine clonidine as comfort medications, or they can be used for MAT as agonist therapy or antagonist therapy with naltrexone. The definition is that you're going to help the period after they come off of opioids, and you're supposed to ease the discomfort. In the day, there was this thought that you should just let people suffer through withdrawals. That would make them never want to use again, but that actually doesn't work and lead to people going out and just relapsing before they even made it through their detox. And so making detox less miserable really helps people to be able to begin the process of recovery. Antagonist therapy is used in the longer term to block the opioid receptors, so patients cannot get high if they take a full-strength opioid. Naltrexone is used for long-term treatment, and it can be given by mouth or as a monthly injection. Opioid agonist therapy is also a long-term therapy, and that's supposed to decrease cravings and improve functioning and reduce relapse rates. And the options include methadone and buprenorphine. Application has sole treatment intervention, even if you've done a very nice detox where you're helping your patient with their symptoms and they're not so miserable during the actual detoxification itself. That is not enough treatment for patients. They will still relapse afterwards if nothing else is done. Assisted treatment is highly effective in helping people stabilize their lives. It's not something that they have to be on forever if they don't want to be. And certainly for adolescents, I would never tell an adolescent, here, take this medication and you're going to be on this medication for the rest of your life. That's for a psychiatric condition or for medication-assisted treatment. In the picture, these are on the street known as the stop signs, and it's a buprenorphine naloxone tablet, and people, you use this on the street to help you stop use substances. American Academy of Pediatrics, a really policy statement in support of medication-assisted treatment for adolescents, because it helps them stay sober and live their lives. And there's a real dearth in America of developmentally appropriate treatment because a lot of adult providers don't understand adolescent development. And so that's why it's so critically important for pediatricians and those who treat younger folks to learn to use medication-assisted treatment. Adolescents can get that in a developmentally appropriate setting. Receptors based on what is binding to the receptor. So there are full agonists, partial agonists, and antagonists. And generally, a full is going to bind briefly and then come off and then bind again. And every time it rebinds to the receptor, it can stimulate the receptor again. And so this quick off, on, off, on, off, on allows full agonist to have a full effect. A partial agonist will bind a little bit more strongly and receptor more slowly. And it's not going off the receptor and stimulating the receptor and so it has less of an effect. And then a full antagonist offers very high receptor affinity and will just bind to and sit on the receptor and block other things from getting in there. Methadone is a full opioid agonist. And there are limited options for patients under the age of 18, but as soon as you have a patient age 18, if they want to get methadone and it's appropriate, you should encourage it, then programs are very highly structured. The patients have to show up, 6 out of the 7 days of the week to receive their methadone. It can be very helpful for people whose lives are chaotic and who need a lot of structure to be able to succeed. On the end, the amount of structure and having to show up and be there every day is very difficult to impossible for some people. And that can make success with methadone, especially don't live near a methadone clinic. Now, some patients who are not successful with buprenorphine in an outpatient setting can be successful with methadone. And so if you have a patient who has not been successful with buprenorphine after several trials, then it's reasonable to talk to them about trying a methadone clinic. If it doesn't work, they're not going to be worse off. They'll be in the same place that they are. Buprenorphine is a really good option. I've been prescribing it for the last 4 years for adolescents, and it works well, and it lets people regain life. The partial agonist properties of buprenorphine mean that it partially stimulates the receptor, and you don't get the full strength effect that you get from a full-strength agonist. So because it's less addicting, the potential for misuse is lower, and it's less reinforcing, but it's still a little bit reinforcing, which is a positive thing, because when a patient comes into your office in opioid withdrawal and you do it with them, give them some buprenorphine in the office, and they feel better from the withdrawal, then that makes them want to use the medication again. Buprenorphine has an FDA indication for treating opioid severe opioid use disorder in patients 16 and older, prescribed in the outpatient setting. And usually the way it's done is you do your initial assessment, you put the patient on buprenorphine in your office where you can observe them, and then give them a very small prescription, maybe 3 days or a week, depending on the patient. And then for the first several weeks, they're on weekly prescriptions. They have to come in, you have to see them, and then you can move them up to every 2 weeks and then every 3 weeks. So it's a lot of visits for the patients, but it also, keeps them more engaged in treatment and helps you know that when they're showing up every week, seeing them, they're giving you a drug test, and you know that they're taking action and doing what they're supposed to do for their treatment. And so it can really be a win-win. The antagonist properties of buprenorphine are helpful because when people are taking it and they strength agonist on top of it, like say they use heroin, usually the buprenorphine is going to block the effects of that heroin, and so they're really not going to get high and they're not going to get that same effect. With buprenorphine, even though you're giving patients, visually who are stable and doing well, like a month's supply of buprenorphine at a time, it's safer than an overdose because it only partially stimulates the receptors. Buprenorphine is generally packaged in the same tablet with naloxone, which is an opioid blocker. And the reason for that is to limit the abuse potential. Buprenorphine on its own could be injected IV, putting the naloxone in it so that if someone just crushes up a tablet of buprenorphine naloxone and injects that, they get a full-strength dose of naloxone, and that puts them into acute withdrawal. In essence, there have been several research trials showing that T is effective in this group. I see. Oh, hang on a second. The computer went to sleep. Just one moment. Okay, it's back. In trials, adolescents. On slide. Can we go back a slide? Word one. There. So in this study, there were 152 adolescents aged 15 to 21 who had opioid use disorder, and they were assigned to two different groups: a 2-week detox, buprenorphine, to just get them off of the opioids that we're using, and then maintenance treatment, or a 12-week treatment with buprenorphine naloxone. For the entirety of the 12 weeks, all patients received group and individual counseling. Next slide. And we found was that over the 12-week treatment, they were doing weekly urine drug screens, and there were fewer opioid-positive urine screens for those who were receiving buprenorphine for the entire 12 weeks of the trial, and the higher retention of participants in those who were in the 12-week group versus those who did a 2-week detox. The way these studies are done, you're always looking for a lower number of positive opioid positive screens, and so you're looking for perfection. It's not always possible to achieve 0 relapses on opioids, say in a 12-month period. But if you can go from someone using opioids every day to having 1 or 2 a year, then you've really improved their lives. One way to get started on improving patients' lives is to take the buprenorphine waiver training. It's our training. Half of it is in person and half of it is online. And there has been a course that's developed specifically to address pediatricians and family physicians who are working with adolescents. Really great course. I highly recommend that anyone who's even remotely interested in ever using buprenorphine, go ahead and take the course so that you can get your waiver from DEA and then potentially prescribe if you need to, even if you were just using it for pain for people after surgery or something like that. It's a good thing to become familiar with. Naltrexone is an opioid blocker. It has an FDA indication for use in opioid use disorder and alcohol use disorder. It binds to the opioid receptor and prevents other things from binding to it. You get high off of heroin or any other opioid if you have naltrexone in your system, because that naltrexone is going to bind to the receptor very tightly and block that drug from being able to access the receptor. In patients who are 18 and over, it's been found that naltrexone is better than placebo for helping people use opioids, fewer times over a time period. And in these people, there is better retention and not as many cravings for the patients on naltrexone. For the alcohol use disorders, I find that it's particularly effective. Naltrexone decreases the positive reinforcing effects of any substance, but alcohol in particular. And people, even if they're still drinking alcohol and they're using naltrexone over time, they tend to drink less and less, like fewer drinks per sitting and not as many drinking days over time. There's not been any studies on naltrexone for substance use in younger people, although naltrexone has been studied in conditions like autism spectrum disorder, and has been shown to be safe for use in children in those disorders. Naltrexone has good bioavailability when it's given orally, and it's metabolized in the liver. One of the big causes you want to think about with naltrexone is just not using people who have problems with their liver, because there have been reports of potential liver damage with some patients. And so we usually check liver functions before and then after starting naltrexone. It lasts for 1 to 3 days with any given dose, and also give a monthly IM injection. And you have to be careful to start naltrexone after the person is fully detoxed off of full-strength opioids, because otherwise you can give them precipitated withdrawal. And usually, if they take naltrexone and they are put into precipitated withdrawal, then they usually will never take it again because it feels so bad. Both forms of naltrexone, the oral and the injection, can be very effective, but the injection does work for retaining patients over time, so that over the course of this study shown below, for 25 weeks, twice as many patients were retained in the injection naltrexone group versus the oral group. So I wonder, how long will my patient be on therapy? And I tell people it's abuse disorders are like any chronic illness that requires maintenance treatment. You've got early stages of recovery or sobriety, longer stages of recovery, sometimes relapse. And then you get back on the wagon and go back to early sobriety. So like if you had a patient with diabetes, they might be in the hospital in the beginning, and then their blood sugars are still running high, but they're working on it. Over time, they have much better blood sugar control. And even if they're doing all of their treatments like they're supposed to be, sometimes they'll still end up back in the hospital or relapsed. And then they just have to start over with the treatment. And so the thing that's important about the treatment is just to keep on working on it and to work on it in different ways from strategies, so that people get all the benefits that they can. It goes into like lifestyle, diet, exercise, that can help. Psychosocial support should always be present. A patient needs MAT, and even if they don't, if they have a substance use disorder. And individual medication needs vary by person, so that some people can be on buprenorphine for a year or two and taper off, and they do fine. some people are on it for many years and they don't taper, or some people are on it for many years, they didn't want to taper, and after it's been 6 years or something like that, they say, okay, now I feel stable, now I want to start tapering. I've seen is that a lot of patients seem to want to start tapering even if they didn't want to before, when they hit their mid-20s. And to me, I feel like their brain finished growing at that point and finished developing, and they seem to know themselves that they feel more stable and feel more able to start that taper at that time. Monitoring is really important with the outpatient buprenorphine. One of the advantages working with adolescents is that their parents are involved in their treatment. So we always have parents come in with the patients for the evaluation. If the teenager is living in the parent's home, then the parent should be doing directly observed medication administration for every dose. Parents do semi-observed drug tests at home and deliver the test to the lab. By keeping the parents intimately involved, then there's a lot more structure, and you can replicate some of the benefits that you get from a methadone program at home with parents working with the buprenorphine program. If a patient is receiving MAT from an outside provider, then you always want to get a release to speak to that provider, notify them about any critical medical updates, and you can still provide some of the monitoring for patients who are receiving MAT elsewhere. You can do a drug test, even just a random test, and if you know that they're supposed to be taking buprenorphine, then you go ahead and add that test on order, and you should see that the buprenorphine and its main metabolite, the norbuprenorphine, should both be in the sample if the patient is taking their medication. Once in a while, you'll see that a sample has only buprenorphine in it and doesn't have the metabolite norbuprenorphine, and that means that somebody dropped a tablet into the urine sample and they're not taking their medication. Conclusion, opioid use disorder is a very serious problem for adolescents, and I think that after today's presentation that some of you will be inspired to go out and try to treat this population. Time for questions.
Great. Thank you, Dr. Deister. We have one question. I bet a lot, if not most, of the recent spike in deaths from opioid overdoses is due to the spiking of heroin with fentanyl or lethal drug carfentanil. To the extent that this is true, why are drug companies permitted to manufacture these drugs? How can carfentanil and fentanyl overdoses be treated, given that they may be resistant to Narcan treatment?
So you're right that there has been a lot of contamination of the heroin supply on the street with fentanyl and carfentanil. And these are manufactured typically in China, and so it's all illegal manufacturing. And then because both fentanyl and carfentanil are so incredibly potent, the amount of space of literal volume that you need to be able to smuggle something is very small. You can smuggle an incredible amount of fentanyl in a very small space, and so it gets in, and then the druggists on the street have no idea how to dose it or how to cut into the heroin so that it doesn't overdose their customers, and that's why there are these deaths. Most people who are using heroin wouldn't really abuse fentanyl or carfentanil, but they don't know that it's in there. The overdose, I think the best treatment is prevention. If if Narcan isn't going to work, then you're going to have to put the person on a vent if you can, or to use supportive measures to keep alive. But keeping people away from street drugs is critically important. And so if they aren't using it, they can't overdose. And that's why it's so important for us to get more buprenorphine treatment available for many of these adolescents and young people who are using.
Thank you. We have one more question. How does naloxone work for alcohol abuse, given that it works on opiate receptors?
I think it has to do with alcohol release of enzymes that would stimulate the opioid receptor and give you a positive reinforcing effect. So that in behavioral theory, reinforcement means that the behavior will be done more frequently after the stimulus. And so in alcohol and you have a positive reinforcing effect, then you're more likely to drink again in a period of time, and you're more likely to drink more alcohol the next time you do drink because of those positive reinforcing effects. And so naltrexone gets in there and just puts a block against that. It's not necessarily a punishment, and that naltrexone isn't preventing alcohol from like GABA receptors and allowing you to get drunk and stuff like that. But people find that they drink alcohol and feel satisfied with how much alcohol they've drank with like fewer drinks per sitting. And they just don't have that part of their brain telling them, drink more, you want more, you want more. That probably it's down. It's actually astoundingly effective. And it can help with alcohol cravings, whether or not someone continues to drink. If they're abstinent, that's amazing. But even if they're not abstinent, it can still be very helpful.
We have 2 minutes and 2 questions. So for those of you that can hang on a little bit, thank you. But I think that we'll address these questions. And just a reminder, you're going to get a survey at the end of the webinar. If you could fill that out quickly, we'd greatly appreciate it. And stay tuned for our next webinar on November 28th. But let's go ahead with these questions. How long is a first induction? Do you have patients stay in the clinic for multiple hours, and are they observed during this time?
So we usually schedule the induction appointment for a 1-hour appointment, although it is nice to have them scheduled earlier in the day so that you don't want to start an induction and then have it be a difficult induction and then you're trying to leave the clinic. So, we like to do it in the morning so that if anything happens, we can take care of it during the afternoon if necessary. But most people can be induced in 1 hour. They come in, they give their drug test prior to the visit. We check for pregnancy in the women, and you need to verify either on that day or previous days, if they have full-strength opioids in the system. They should be withdrawal, so you use a COWS scale to see how bad their withdrawal is, and then administer the first dose of buprenorphine. Usually give 2 milligrams, and then 30 to 45 minutes later, check them again with another COWS and see what their symptom reduction has been, and then potentially give them another dose before they leave clinic. And then, depending on the provider, some of us will call the patient in the evening and just check on them, see how they're doing, and tell them whether or not they should take another dose that evening. And then we like to see them back within 3 days if we can, or a week at the most after the induction.
Great, thank you. This is going to be our last question. If folks have additional questions, or I know at least one person typed questions into the other question box, send them along, and we send them to Dr. Deister to answer your questions after the webinar. So feel free to send them. So this last question is, I'm a primary care pediatrician and have been waivered since spring 2017, but I'm not sure how to connect with those adolescents and young adults who need help. Are there programs actively looking for waivered pediatricians?
People are out there, and you could put your name on the there's a registry or like a website that the federal government has lists all the Suboxone providers, and so if you put your name on there, you would probably be swamped with people wanting treatment within a month or two. But if you're looking specific for adolescents, they're out there. I'm not exactly sure where you're living or what your situation is. Are you in the outpatient setting?
They're muted.
They're muted. Oh.
I think would be
I think that
best
maybe
is
that
I
would
could
be a
connect.
better offline question.
Yeah, I could connect the two of you.
Okay.
After the webinar.
Okay.
All right, great. Well, thank you to everyone for participating. This is obviously a critical topic. We know this is a huge problem, and you're all on the front line seeing kids and are in a position to be screening and asking questions and identifying kids who may need help. So thanks for participating today. We look forward to having you join us again in November, and many thanks to Dr. Deister for sharing your expertise.
Thank you. And thanks to everybody for participating.